Thank you, Dr. Lantz, for coming. This is such a pleasure to have you here. Dr. Lantz is a maternal fetal medicine specialist with over 20 years of experience in clinical practice. He attended the University of Maryland School of Medicine and did his residencies at UBMC and Johns Hopkins. Board certified in obstetrics and gynecology and maternal fetal medicine. He spent 5 years on the faculty of Johns Hopkins before starting private practice, and he's been the medical director of maternal fetal medicine at Anne Arundel Medical Center for 6 years. But I think his biggest accomplishment is that he married a genetic counselor. So very excited for that.
Very, 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 very smart man. Yeah, very, very smart man. Well, thank you guys for having me here. It's a pleasure. I really have to start by saying how wonderful your fetal medicine center has been to our patients. I hope this is not going out over the the internet or anything, but I was very Hopkins devoted throughout my training and my professional career, and I've become a children's convert on where we send our patients. And you guys see our patients during very, very difficult circumstances and under difficult conditions. And I've never had anyone come back to me and say they were dissatisfied or not pleased with the care they had gotten here. So kudos to you. You're doing wonderful, wonderful work. And the way that you treat your referring physicians should be a model for the country on getting back calls, phone calls, reports, being available. So on our side, I just want you to know how much we appreciate all the work that you're doing here. And Meg asked me to talk. I was, very, very excited about that. And then I said, what would you want me to speak on? And she said, how about growth restriction? And I was like, wow, nothing gets me more excited in MFM than talking about fetal growth restriction. So I think it's more, in an attempt to try to make this a little bit more interesting, I thought we would start with 3 cases. And these are actual cases that we had at our center. And the first case is a 37-year-old para-0 who came in for first trimester screening and genetic counseling for maternal age. She really had no significant past medical history, and at that visit, her blood pressure was normal. This is her first trimester screen, or this is her crown lump length from her nuchal translucency screen. The gestational age is 12 and 4, and you can see it matches up perfectly. So the growth at this point was completely on track. The only finding that we had on the ultrasound at that point was a fibroid. You can see to the right there. So this is her scan. At the top, you can see 19 weeks and 4 days. And the femur length is lagging. It's at the first percentile, about a 2-week lag. The humerus is also lagging, but not quite as dramatically. But of interest, in this case particularly, I find interesting, is the abdominal circumference was completely normal at the 41st percentile. So at this point, we didn't know, are we dealing with some sort of skeletal dysplasia? There were no other anomalies on the baby that we could detect at this point, so we continued to follow her. So she came in for a prenatal visit at 24 and 0 with new onset hypertension. Her blood pressure at that prenatal visit was 170 over 114 with new onset 3+ protein. So obviously at that point she was sent over to labor and delivery. And we have a really, really crappy ultrasound machine on our labor and delivery, so please forgive these pictures. But this is her abdominal circumference at 24 weeks. You can't see it because it's cut off at the bottom of the screen. But the abdominal circumference was measuring 21 weeks at this point. Again, you can see that the femur is lagging by about 4 weeks. And this was her Doppler of the umbilical artery. You can see there's absent end diastolic flow. So this is her actual fetal biometry, and you can see there's lagging in all measurements, although we did not see any anomalies on the baby, and the long bones appeared normal at this point. So on labs, she was evaluated for preeclampsia, and she had elevated liver transaminases and borderline low platelet count at 142. So the plan was to give her betamethasone, magnesium sulfate. Obviously, she had a diagnosis of preeclampsia and delivered 24 hours after the second dose. And she actually got delivered a couple weeks ago, and the baby weighed 370 grams. But amazingly had APGAR scores of 7 and 9. This baby is still alive at this point, which just shows with early onset severe preeclampsia can be a cause of fetal growth restriction. The second case is a 28-year-old para 2002 who presented to our center for a lagging fundal height at 26 weeks. Her prenatal course had really been uneventful up until that point. So we did an ultrasound, and this is a transverse view of the fetal abdomen. You can see there's multiple hyperechoic areas within the fetal liver. Even more striking on this picture, I think. So we didn't see any intracranial calcifications, but she underwent amniocentesis, which was positive for, the PCR was positive for CMV. So this actually ended in a demise later in her pregnancy. Are you guys treating CMV?
We don't actually do the treatment here. Our fetal ID program, our prenatal ID program, has picked up a lot on the sort of burner of Zika. And so we are definitely moving into it's become an area that we're really involved in. Yeah.
These are very, and as Meg I'm sure will tell you, these are very hard patients to counsel because it's really hard to predict, long-term sequelae from CMV prenatally, but tends to be worse when you identify it when there's actual findings of CMV on prenatal ultrasound.
Thank you, Dr. Lauren.
Were the long bones, on this baby very short?
No, they were actually normal. The only finding was what we thought was IUGR and the liver calcification.
Okay, it was symmetric.
It was symmetric, yeah, it was symmetric. So unfortunate case. The third case is a 34-year-old para 1031 that we actually did not see early in her pregnancy, but got called in because she had presented to labor and delivery at almost 34 weeks with the right lower quadrant abdominal pain. I don't know if you guys deal with this at all, but we have a lot of outside ultrasound places that are doing anatomy surveys, even on high-risk patients, and I'm not sure how I really feel about that. I think these patients really should be referred to MFM for these type of ultrasounds, particularly if there's any abnormal findings. So this patient had an anatomy survey at one of our private groups, and there was no abnormalities reported on the ultrasound, although they could not clear the 4-chamber heart and outflow tracts. And again, like I said, normally that would be referred to our, something that would be referred, but it never quite got followed up on. So when she came into labor and delivery with the right lower quadrant abdominal pain, they saw some decelerations on the fetal heart rate monitoring. So Dr. Spencer, one of my partners, was called over to do a biophysical profile, which was normal. But this is again, I apologize for these images because we have a crappy machine, but this was the BPD, which retrospectively was probably normal because the baby was brachycephalic, but the head circumference overall was lagging quite a bit, almost 4 weeks. And again, the abdominal circumference was was lagging even more than that. And 6-week lag. And this was her umbilical artery. Fluid was normal, as you can see, but this was an abnormal umbilical artery Doppler with no end-diastolic flow. So at this gestation, here's the complete biometry, as you can see, really lagging in the long bones as well. So the plan was to put her on continuous electronic fetal monitoring and give a course of betamethasone and again deliver after the second dose because of the severe IUGR and the absent end-diastolic flow in the umbilical artery. So this baby was born about a little bit over 2 pounds, 2.5 or 2 pounds 5 ounces with the APGAR scores there. But upon delivery, there was suspicion of trisomy 18, which was subsequently confirmed, and this infant died at 3 days of life. It was cardiac anomaly, yeah. So this baby had double outlet right ventricle, which again was not detected prenatally. So again, multiple causes of intrauterine growth restriction. That's the exciting part of the talk. Now we'll get down to the nuts and bolts part of the talk. But I think there's a lot of I don't know how you guys do it here. I'm trying to restrict my use of SGA for newborns and use the term constitutionally small fetus for those that we think are normally grown but fall below the 10th percentile. And we struggle with this every single day in differentiating true fetal growth restriction from just babies that are constitutionally small. And again, we're trying more to use the SGA terminology for infants who fall below the 10th percentile. Again, the definition, most of us clinically that are in clinical practice, not in the academic arena anymore, really use an AFW that falls less than the 10th percentile. But just using that simple definition certainly has its limitations. So it doesn't really take into account the individualized growth potential of each fetus, and that's kind of where I think the future lies. And interestingly, it's really going to fail to identify fetuses where the estimated fetal weight is above the 10th percentile, but they're not achieving their growth potential. And does this group of patients or this group of fetuses have an increased risk for adverse pregnancy outcome? And how in the world do we identify those patients? And then again, it may result in diagnosing fetal growth restriction in cases where the fetus is just constitutionally small. So these are the things that we struggle with really on a daily basis because we don't want to be over-alarming to mothers when we think that the baby is just constitutionally small for gestational age as opposed to growth restriction. So I think we're going to, in the future, be more refined in how we go about making the diagnosis of constitutionally small fetus versus fetal growth restriction.
Do you take the trajectory of growth into account with that?
We do.
Yeah.
We do. So, so if we have a mother that comes in, she's 24 weeks, but the baby is falling less than the 10th percentile, the amniotic fluid is normal, and all the Doppler indices are normal. We tend to look at that, with the trajectory of the growth. So she comes back in 3 weeks, and the baby's at the same growth percentile, but on a normal kind of growth trajectory. We get much less worried about those patients than we do that with someone where the growth continuously falls further off. So again, we try not to be alarmist when we think that this is just a constitutionally small fetus, but it's always in the back of my mind that should we be testing these patients, as they get closer to their due date, even though we really feel in our heart of hearts that this is just a small baby that's normal. So we really break the etiologies of fetal growth restriction to maternal, fetal, and placental. Maternal conditions, which you guys are all familiar with, the one that we see by far and away the most is hypertensive diseases in pregnancy. And we tend to follow our moms with hypertension every 4 weeks for growth, and we initiate fetal testing beginning at 32 weeks. Antiphospholipid syndrome, a lot of patients with pregestational diabetes. Thing to remember is that while most the higher risk is for macrosomia, diabetic patients that have vascular disease are at risk for intrauterine growth restriction. So your patients with retinopathy, those type of things are at risk for growth restriction. And for some reason, moms with renal insufficiency and cardiac disease are also at risk for intrauterine growth restriction. What you guys probably see a lot of, fetal conditions. Again, we talked a little bit about infectious causes, genetic disorders, are obviously a cause of early intrauterine growth restriction, which we worry more about. And we don't really have a strict cutoff, but as far as offering genetic testing, when we see intrauterine growth restriction, but we tend to, or at least I do, I tend to always offer it if it's identified before 24 weeks gestation. Even if there is not an anomalies, we'll offer them non-invasive prenatal testing and amniocentesis. Structural disorders, congenital heart disease, and gastroschisis, even though the abdominal circumference is obviously skewed because of the gastroschisis, those babies tend to be more growth restricted and also have a higher risk for fetal for stillbirth. Placental dysfunction is one that we really struggle with because unless you guys have, I'll charge you guys with coming up with a way of looking at the placenta directly and telling me that's abnormal, because I haven't been able to do that in my career. So we're really left with kind of indirect measures that we can look at. And I thought in researching this talk, one thing that I was unaware of was the high incidence of placental mosaicism in unexplained fetal growth restriction, almost to 10%, whereas in our moms that undergo chorionic villus sampling in the first trimester, we only encounter that about 1% of the time.
Can you explain what you mean by placental mosaicism?
Meg, you want to
So the idea that, egg and sperm come together, and maybe initially they come together with some, and then that abnormality. The idea of like trisomy rescue idea. Placental mosaicism is just where the placenta has some abnormal cells in it, but the fetus doesn't. So there's a mosaic placenta or a fully abnormal. You can also have a fully abnormal normal.
So there can be there can be an abnormal cell line along with a normal cell line. We've had very interesting cases of trisomy rescue, where we do the CVS and it comes back showing a mosaic pattern, and the fetus looks normal. So those patients we would obviously offer amniocentesis to confirm the diagnosis. But I had no idea that placental mosaicism was that common in fetal growth restriction. And then there's other umbilical artery abnormalities, the two-vessel cord that you can see here, filamentous cord insertion. We've become much more diligent, I don't know at your center, we've become much more diligent at looking at the placental cord insertion in the hopes of picking up these filamentous insertions, and particularly vasoprevia, which obviously we want to know about prenatal. Here's a Doppler of that same placenta. We actually would worry clinically about it after 24 weeks. And people are struggling with, when do you deliver these moms? Because obviously, if there's a bleed from a vasoprevia, the baby will most likely sanguinate. We've actually had two patients in the hospital with plans on delivering between 34 and 35 weeks that had bleeds, and the baby did not survive. And that's right, having the mom directly on the labor and delivery unit. So I think people are pushing back the gestational age of delivery of a true vasoprevia. And some folks are delivering these moms as early as 32 weeks. We're trying to get to 34 because there's really nothing, even if you have the mom hospitalized, sometimes there's not anything that you can do because, again, the fetal blood volume is so small compared to maternal. So we worry much more about vasoprevia than we do placentoprevia. Placental dysfunction, you hear a lot about, what are these unexplained high AFP, unexplained low PAP-A, what does that really mean? And we use a cutoff for PAP-A of 0.3 MOMs to follow for growth restriction. And we are following our patients that have an unexplained elevated AFP also for growth restriction. But looking at these, they really do have a low positive predictive value. If you combine them, low PAP-A, high MSAFP, the positive predictive value increases. But again, the vast majority of these women that have these unexplained abnormalities in their serum analytes for genetic screening for spina bifida, will have normal pregnancy outcomes. But we do follow them.
You follow them monthly?
Monthly, yeah, every 4 weeks. So I'm much better if I kind of understand the biophysiology of, what's actually happening and trying to explain the ultrasound findings. And this is from Dr. Resnick, his kind of take on what are the sequence for Doppler changes with fetal growth restriction. So the first thing that happens is really a reduction in umbilical venous flow. So what happens in that situation is a compensatory reaction where the venous flow is directed away from the fetal liver and towards the heart. And this is thought to decrease the overall size of the liver and result in a lag in the abdominal circumference that we see on ultrasound. So the second thing that happens in that sequence is there starts to be an increased resistance in the placental vasculature, which again, we have no way of looking at a placenta and saying, okay, this placenta is, there's thrombosis here, there's infarcts here. And really grading placentas based on the calcification and appearance really is not very specific towards this. So what you start to see is a diminished flow at the end of diastole in the umbilical artery, thus increasing your SD ratio on the umbilical artery. And then, of course, blood will get preferentially shunted to the brain, and this is going to increase the end diastolic flow in the middle cerebral artery. So as we go further down this path, as there is an increase, more of an increase in the placental vascular resistance, you get into the picture where we see absent or reversed end diastolic flow in the umbilical artery. And then the loss of the brain-sparing hemodynamic changes. You'll see actually at the end some normalization in the MCA Doppler indices. And then as it starts to affect the heart, the cardiac performance deteriorates, and you have absent or reversed end diastolic flow in the ductus venosus. And sort of like a pre-terminal, these are pre-terminal events. You'll see pulsatile flow in the umbilical vein. So the question from a clinical standpoint is, how do we manage these patients and when to pull the trigger on delivery? And I think that the important thing that I always try to remember is the easiest thing is to deliver the baby. I mean, that's the easiest thing, right? But, you are always wanting to prolong the pregnancy in order to improve the neonatal outcome. So with absent or reversed end diastolic flow, we tend to watch those patients almost on a daily basis. And as I get older and as I get more blockage in my coronary arteries, it's really hard for me to sit on a fetus that has reversed end diastolic flow, and really at any gestational age, although there are people that will do that. I just don't have the coronary arteries for that anymore. So this is actually another patient that had hypertensive disease who really had some subtle findings. At this point, she was 23 5/7 weeks and had normal growth. The fetus had normal growth, but her pressures were starting to creep up a little bit. She didn't have any proteinuria at this point. But really, this was the first finding, and this was at 23 5, where we started to see an increase in the umbilical artery SD ratio. And, with all the fancy Doppler studies that we can do, really the one that we base most importance on is still the umbilical artery. We use ductus venosus, we use MCA really only as adjunct data in trying to make decisions. We don't really base our management solely on those indices, but we really depend heavily upon the umbilical artery. So this was her at 23 5. Really the only thing that we saw at that point, again, the placenta there looks normal. So I'll leave it to you guys to figure out, looking at that placenta and telling me that this is going to turn out to be a completely abnormal pregnancy. So this is her 3 weeks and 2 days later, where we did a growth. It was severely growth restricted at this point over a 3-week period. And then here you can see reversed end diastolic flow. I don't have a pointer, but you see the flow during end diastole below the line, which indicates reverse flow in the umbilical artery. So she got delivered at this point. This is just an example of reverse flow during atrial systole in the ductus venosus. And you can see that the A weight there is inverted. So again, this is sort of pre-terminal changes. So what's happening, what people are doing are they're looking at these extreme premature infants that have no end-diastolic flow or reverse end-diastolic flow in the umbilical artery 24 weeks, 25 weeks. So can we sit on these patients and not deliver them? Is there a way that we can monitor these moms? And this is where the monitoring of the ductus venosus comes in. And there's one very good study that showed when this was implemented that they were able to significantly increase the gestational age for delivery in these infants. So again, we're using this sort of as adjuvant.
So meaning that this became the trigger point to deliver?
Yes. Yeah.
Okay.
Yeah.
You wouldn't sit on this.
No, this is pre-terminal. This is what we think is pre-terminal finding. Exactly. So you have a 24, 25, 26-weeker that has no that's growth restricted, that has no end-diastolic flow or reverse end-diastolic flow. Is there a way to know when to pull the trigger, not just based on right? So you see this. As long as the flow and there's no absent end-diastolic flow or reverse end-diastolic flow in the ductus venosus, some authorities are say you can sit on those patients. With absent we have, but again with reverse end-diastolic flow, I'm hard pressed to say that we've ever really sat on that, because of such a significant risk for demise.
What do they look for?
Really, this is the one that's been used the most, is the blood flow in the ductus venosus. Right. And the other ones that have been used, MCA, uterine artery, we really haven't implemented into clinical practice. Although they're getting done. But is there a way? The question: is there a way to know when's the best time to pull the trigger on these babies that are with extreme prematurity? And very, very difficult question. It causes me to lose a lot of sleep at night when we have one of these cases. But I can tell you, we've had cases, where there's been absent end-diastolic flow for weeks, and the baby, from a biophysical standpoint, still looks good. The amniotic fluid is normal, but again, you're always worried, no matter how frequently you're monitoring them, are they going to come in with a fetal demise? And we waited too long. Like I said, the easiest thing is to deliver the baby and put it onto the child. Exactly. But we really have to resist that. We really have to try to make sure we optimize the intrauterine life.
You're getting off.
Exactly. And we'll touch on that in a minute here. That the babies may be born alive, but overall, you may still have the same number of neonatal deaths. So it's a very, very difficult question, one we struggle with in clinical practice every day. This is just an example of the MCA Doppler, which can be used again as an adjuvant, but we're using this mainly for RBC alloimmunization. So, how do we manage these patients? We've touched on some of these points already, but really there's three key elements that we look at. Interval fetal growth. I argue with my partners sometimes because I'm a big advocate, particularly after 28 weeks, of really giving the baby a three-week interval before evaluating growth. Some people will do 2 weeks. But if you look at the range of error with fetal biometry in the third trimester, it really is plus or minus 3 weeks. So the way I look at this, the last thing I want to do is measure a baby at 2 weeks and see there's no interval growth, but just miss that it was only due because it was outside the range of error of the measurements. Okay, so if I'm going to pull the trigger for no interval growth in the third trimester, I really want to see a 3-week interval where there's been no fetal growth. 24 to 28 weeks, sure, every 2 weeks, but really in the third trimester, I'm really worried about the range of error of the measurements and calling it no interval growth when it's really just due to the range of error in the measurements. And we do a lot of fetal testing, usually twice a week. We'll do twice weekly non-stress tests and once a week biophysical profile and Doppler studies. And then again, looking at the Doppler indices, mainly in the umbilical artery. Again, so we touched on fetal growth intervals. So our approach, and this is not really scientific, is again the twice weekly fetal testing. Using the non-stress test and just AFI, which we refer to as a modified biophysical profile, is also appropriate. And then if we start to see absent and diastolic flow, we're going to monitor those moms every day. Again,
keep them in-house, or do you bring?
We've done both, depending on how far away they are from the hospital. There's really little consensus as to the optimal timing of delivery. And I can give you the references, but for the sake of time, I didn't want to go through each and every trial that's been done. But there's really 3 major trials that have been done. And to summarize those findings, delayed delivery of the very preterm growth-restricted fetus results in some stillbirths, okay? However, and this is the point that we touched on here, immediate delivery produces an almost equal number of neonatal deaths. Okay, so again, the easiest thing is to deliver the baby, but are we really benefiting that patient and that fetus? Delivery or expected management after 36 weeks results in similar outcomes. And again, Dopplers of the MCA and ductal stenosis can really be used as adjuvants to the umbilical artery and umbilical artery Doppler studies. So this is kind of this is our algorithm of delivery management. So if a baby is normal, if the baby continues to show interval growth, the twice weekly fetal testing is reassuring, and we have normal umbilical artery Dopplers, we're waiting until 39 weeks to deliver that mom. However, if we see reverse in diastolic flow greater than 32 weeks, they get delivered. Again, honestly, to be forthright, really we would if we saw a 25, 26 weeker with reverse in diastolic flow, we may try to get betamethasone on board if we could, but really not waiting much longer than that. If we see absent and diastolic flow greater than or equal to 34 weeks, we're delivering that mom, and then we're delivering for oligohydramnios at 37. So kind of what the future holds. I don't know if you guys get the American Journal of OB/GYN. They sent out a whole supplement on fetal growth evaluation and management. And this is everything and more that you would ever want to know about growth restriction. It's very, very detailed. But sort of the future, I think, is really customized growth charts. And what do we mean by customized growth charts is we understand that there's non-pathological maternal factors that can affect birth weight, meaning pre-pregnancy weight, height, parity, even fetal sex. And this is going to, if we are more specific in our growth charts, then maybe we can look at the individual growth potential of each fetus. There's been quite a bit of research, and these customized growth charts are probably coming down the pike to be used in clinical, although at this point they haven't been shown to improve outcomes. So just to give you one example of a customized growth chart, the NICHD, the prenatal research branch, developed a customized growth chart for African-American women in the Detroit area. So they looked at 4,000 African-American women and 182 Caucasian women from the Detroit metropolitan area. And all of these had ultrasounds between 14 and 40 weeks gestation. Of interest from a plausibility position is the median number of ultrasounds was 5, and how that's going to affect, because with these customized growth charts, you really do need to perform multiple ultrasounds during the course of the pregnancy, and whether that's going to be, covered and what that means from a financial standpoint, that's yet to be determined. So the regression model that they used included maternal height, weight, parity, and fetal sex, and some interesting findings, I think. So the mean birth weight at 40 weeks was 133 grams higher in Caucasian women, and male fetuses overall weighed 150 grams more and maternal weight, height, and parity had a positive effect on birth weight. So by using this customized growth chart and applying it to that specific population, these authors felt that they were more likely to identify fetal growth restriction. Yes, yeah, so bigger mom, taller mom, more children, all had a positive effect on birth weight. The other thing that you guys are probably going to start hearing more about, and this is, I think, even more exciting, is that abnormal fetal growth velocity, okay, the rate of growth in the abdominal circumference, may be associated with perinatal morbidity. And it even would be a stronger association than smallness in predicting neonatal morbidity. So just to give you an example, and this is pulled from this supplement, so this is an example of abdominal circumference growth velocity. So you can see menstrual age in weeks, gestational age in weeks on the x-axis, and on the y-axis is abdominal circumference. So the red dots are 3 ultrasounds that this individual patient had, I guess 19, 22, and again at 25 weeks gestation. So those are the 3 red dots. And the solid line indicates the projected growth velocity for the abdominal circumference in this individual fetus. That's the hash mark line. So the black dots are 4 subsequent ultrasounds performed in the 3rd trimester. And that gives you a kind of an idea, and the shaded area is the normal range. So by identifying, this is kind of the same thing, the shaded area is the AC reference range. So the thought is that you could individualize these growth charts based on the growth velocity of the abdominal circumference, and this may be a better predictor of neonatal morbidity. The interesting thing that you'll see is that this particular patient had 7 ultrasounds. And really, how does that, can you imagine the volume of patients? We see 100 patients a day in our office, and it would be overwhelming for us to actually do this. So how is this going to be implemented into clinical practice is yet to be determined. We have 4. So yeah, this is coming down the road, the customized growth charts, and with current technology, there's computer programs that will allow us to do that. I think it'll be more sensitive in picking up growth restriction.
Let's go back to that graph again, Lynn.
Sure.
But do you expect it to be linear, the growth? I mean, I sort of, some organs are more exponential towards the end, right?
Right. For the abdominal circumference, pretty much. That's why they're using it. They've also looked at femur length and creating. It doesn't have to be a linear curve. I mean, it could be any kind of curve. They looked at femur length. They looked at other fetal biometry, but the abdominal circumference seems to be the one that may be most predictive of adverse outcome. So yeah, but from a practical standpoint, 7, 8 ultrasounds, during the course of the pregnancy, is that really practical and doable in our current situation that we have? So I tried to make fetal growth restriction as exciting as possible for you guys, but I'd be happy to answer any questions that you would have at this